You'll see in the agenda there are some questions, but what I'd like you to do is think about the questions as you reflect on each speaker so that we can have all the speakers have an opportunity to make their presentations, and then we'll take some time to discuss. So next up we have Rob Smith from Health Education England, and he will be talking about clinical pharmacists.
Yeah, good afternoon, everyone. Firstly, wow, that's fantastic, Wazile. If I was a taxpayer in whatever county it was in Kansas, I might want your university and be willing to pay my taxes to get it. What I'm going to talk about is Health Education England holds a £5 billion training budget for education of clinicians, and of course we also sit within a fully state-funded health system. So some of those affect the context of what we're going to talk about, but basically I wanted to give you some insight into how we've attempted to solve some of the mismatches that we've discussed in terms of the model, and by doing so explore the causes of those mismatches and perhaps help us validate the model as we go forward. I think that's kind of part of the aim. So what was the problem? What problem were we trying to solve? So basically, it was a mismatch between need on the left-hand side of the model, I suppose, that said we definitely need more clinicians working in primary care and the community sector, and what we were getting. And this is the kind of history of the growth of the medical workforce in England over the period 2003 to 2013. And you need to remember all of this growth happened as a consequence of publicly funded education. So we had the money, we had control, in theory, and yet our policy goal and our attempt to meet need, you could argue that kind of graph says not so sure we've achieved that. So in our breakout session later we'll be discussing that state funded doesn't always mean you pull the right levers in the right way. So that was the past. This is the future. There's an absolute limit to how quickly we can grow GPs as primary care clinicians. When we came into doing this work, we thought this was about funding. We thought there's not enough money being put in to create GP training places. So we created some money, well done us, with our taxpayers. And then everyone said, no, actually we haven't got the physical capacity or the consulting rooms or the faculty. So we created that as well. And in 2015, I think we had about 2,700 posts in 2014, and we created 400 more. And we advertised for 3,100 trainees. And we got 2,700 because people wanted to do other things. So it wasn't until we'd addressed what we thought were the root cause of the problem that we ran into Edson's model. And what is it you want to study in, and what are the returns, and why would I want to be a general practitioner? And in theory, we're going to go up to 3,250, and we're throwing the kitchen sink at incentives to get people to do it. And if we achieve it, this graph kind of curves up a bit, and that would be a good thing, I think. However, talking about need, so this orange line is a kind of an assessment of need. How many GPs do we need? To be frank with you, it's the lowest of the lines I could have showed you. I could have shown you a much bigger gap. And it says we've got a current gap between need and supply. It says the need's going to go up because we've got aging population, long-term conditions, etc., etc. And your GP supply is not going to meet it until sometime in 2021, which isn't good news for your Secretary of State or the government who are trying to implement a policy. Need and demand, we've got no idea how many actual posts there are and how many are vacant. So this is an expression of need based on activity and population and epidemiology. We don't actually know whether there'd be jobs for those people to go into when we finish training. Always a bit of an issue when you're investing this kind of money. So if that's the situation, and you've definitely got some need and you're not going to meet it because you know you've got a constrained supply, you're left with the conclusion that in the medium term at least, you have to move to a multi-professional team-based approach. You may say you should have been doing that in the first place, and I wouldn't disagree with you. And it is that kind of piece where, due to supply constraints, you're forced into a more kind of innovative solution, and maybe what you'd call an asset-based solution, i.e. don't focus on what you haven't got, focus on what you have got. And one of the things we have got is a lot of graduate pharmacists coming off the pipeline. Interestingly, because we opened up lots of fee-paying, debt-based pharmacy schools. So we could go into another aspect of mismatch on this one. It's got everything. So here, what happened? So basically, we got government commitment to the idea of supporting a multidisciplinary, multi-professional primary care team. Secretary of State said, we're committed to having 10,000 clinical professionals, of which 5,000 would be doctors. This was in an election year. It would have been very easy for him to say 8,000 doctors. Totally unachievable, but he could have said it. It would have been a popular thing to say. So we kind of got some backing. HE then commissioned a kind of study into the art of the possible, led by Professor Martin Rowland, who's a GP and academic, going out finding good examples of good practice. You know, and it's very much a kind of proof of concept thing. I forget who was saying earlier, you know, you've got to sell this to the public and the professions. You know, is this multi-professional team as good as a doctor? And there are lots of examples that when it happens, people love it. But you've got to say, I'd prefer to have 8,000 GPs, thank you. You know, you've got to get over that. And then a year later, it translated into what social medicine systems and public funded do best, which is deploying some big hard cash to try and get it done. This is a document actually owned by an organisation called NHS England that hold the health budget, £100 billion worth of health funding. We're their junior partner, we're only the 5 billion. And this is basically a wider strategy for how we improve primary care and meet that primary care need. So to come on to the example I was talking about, clinical pharmacist program is one aspect of that wider strategy to meet need. What is it? It's about registered pharmacists getting additional training to provide direct patient care. We try not to use the word substitution. It's very emotive, isn't it? Pharmacists can't do what I do. No, but they could carry some of your workload. You know, it needs to be a more positive kind of vibe. I understand that. Who are they? They're experienced pharmacists. This isn't about the excess graduates going into something they're not ready to do. They have to be able to have independent prescribing. So they've probably been in practice for some time, for 2 or 3 or 4 years. The training's in service, i.e. they're in a practice, they're employed. You know, it's not some academic exercise and then you try and find a job. You're in a practice already, learning the human interactions with your teammates as well as the academic bit. But there is a specifically designed national learning pathway and programme with the University of Manchester that means that there's a homogeneity about this programme across the country. But this was pretty critical too. We've given practices organisational development money. You know, we don't just drop in this new thing. You know, how do we create fertile ground for this to work as a team? It was a really critical component. You know, it'd been very easy just to do the academic bit. I've shared this with you. I mean, I think I've got the link somewhere else. But so, what was it meant to do? I think this is part of selling it to the public and the professions. So what are these people going to do? I've not, you know, what's their brand? I know doctors, they've been around for hundreds and hundreds of years. What does one of these people do? So medicines management, long-term conditions, and guess what? As the population moves to a long-term conditions-based piece, it's very kind of attractive. Again, for those of you that are interested, what does that extra training mean? You know, this is a retooling exercise, isn't it, Arian? You know, so these kind of areas, consultation, clinical assessment, you know, some pharmacists are, you know, really terrified about the interaction with the patient. You know, especially, so interestingly, our community pharmacists, Dr. Water, hospital pharmacists, oh my God, I have to talk to people. You know, tricky stuff that GPs, you know, learn in their sleep. And guess what, although this is structured, each person will be assessed on entry to see what they've got already, and therefore you add on to it, you don't do all 9. So let's talk about the big bucks and what it means in terms of impact. So what is there? There is an 18-month training programme. Costs about £8,000, $10,000, 100% state funded by us. Here's the killer though, 3 years of subsidised employment. Are there any jobs for people? Where do we get the demand side? Let's not do the supply end and then go, oh dear, we've got no jobs. So this is a kind of a big bribe to say, can we get you interested? It's tapered, so you start with 60% subsidy, go down to 20, and then nil, okay? And as you'll see in a minute, the numbers on that side are much bigger than the training effort. So we had a pilot. We weren't sure this was going to work, so we've done the work with the University of Manchester. We said, let's try 50, see how it goes. Within a couple of months, people were knocking the door down, saying, this is definitely what we need. So we've got to 470 effectively in the first cohort plus, and that's what are currently in training right now in the system. So that's going to cost us £3.5 million in training. It's going to cost NHS England £31 million over a couple of years. So reasonably big bucks, but we're hoping this will lever some significant change. So that third document I talked about, which is a big effort to try and get the whole of the primary care community to believe that the NHS is taking them seriously, said, let's try clinical pharmacists for every 30,000 population. Let's have a further 1,500 by 2020. And let's spend £100 million doing it. And there's every indication that there is both the desire from the practitioners and from the general practices themselves to do this. But I think this is interesting, which is, I've been part of some of these exercises before. We did non-medical endoscopy with a bloke called Mike Richards, who was our cancer czar back in the day. And we created hundreds of non-medical endoscopists working in multi-professional teams. And then we mainstreamed it to say, okay, employers, over to you. And then that didn't happen. And last year, the Secretary of State asked us to reinvigorate a non-medical endoscopy programme. So state funding, which we'll discuss later, how do we know that our kind of core funding, the money that's going into primary care as part of the tariff for service, and the value of the role that's observed by the practice will get us to a position where it's the practice or employer or student that's funding this in the future? One of the problems when you get a bit of maturity is people say, oh, I really like clinical pharmacists as a model. And when mine retires or leaves, I'll stick an advert out. I'll try and get someone else has trained. And that's one of the failures we see, which is advertising hope becomes your HR strategy rather than train your own. And at which point you could say, well, maybe you should do state funding all the time and just bite the bullet. And that's a question I think we might discuss in the output groups. So that's it. I hope that's kind of illustrative of what we're talking about, and happy to take any questions at the appropriate time.